Good morning, good afternoon, and good evening, everyone, from wherever you're joining us, and welcome to today's webinar titled Understanding Intracranial Pressure in Freely Moving Rats, featuring Dr. Connar Westgate, postdoctoral fellow at the Danish Headache Center at the University of Copenhagen. Today, he'll discuss his research on the importance of intracranial pressure measurements and how this parameter can be used to understand the central nervous system function. I wanted to take this moment to thank our sponsor for this event, AD Instruments, for making it all possible. All right, and with that, I'm very pleased to welcome Connar to the floor.
Yes, thank you for the introduction, Sarah, and thank you for the opportunity to share and discuss my work. So today I'll be discussing our work in understanding intracranial pressure in freely moving rats. But before I sort of discuss the work, science doesn't happen in a vacuum. We all work as part of a team. So it's always useful to actually talk about those who we work with. So I work within a group that is part clinical and part basic research. We're led by Professor Rigmor Jensen in the clinic with a postdoc, Johanna, and PhD student, Nadia. On the basic science side, we're led by Sajday Eftekari. We also have Ida and Snor, PhD students within our group. We have Christina, our research assistant, and Louisa, our master's student, and of course, myself. And a little bit about myself. I did my PhD at the University of Birmingham in the UK under Professor Alexandra Sinclair, where I focused on understanding the adipose and endocrine biology of idiopathic intracranial hypertension, or IH, which is a disease of raised intracranial pressure, which I will describe in a bit more detail in future slides. Currently, I've been a postdoc at the Danish Headache Center for 3.5 years, under the aforementioned Rigmor Jensen and Sajday Eftekari, where my work has predominantly focused on understanding rodent intracranial pressure and how factors associated with IH can modulate intracranial pressure. And during the whole of this time, I have conducted telemetric ICP measurements. So what is intracranial pressure? As the name would suggest, intracranial pressure is the pressure within the cranium. This is determined, according to Monro-Keller hypothesis, by the volume of the brain, blood volume, and the cerebrospinal fluid, and the fact that the cranium is a rigid box, so any change in volume there will increase pressure because it's not the compliance of the bone to expand or contract with pressure. When ICP is dysregulated, many symptoms can occur, such as headache, papilledema, which is swelling of the retina, cognitive disturbances, and if left untreated and get severe, ultimately death can occur. And in the context of brain health, you want to avoid anything which alters how the brain may work. And there are several conditions of raised intracranial pressure. These include hydrocephalus, brain tumors, pseudotumor cerebri, any kinds of trauma, stroke, and a more specific kind of pseudotumor cerebri, idiopathic intracranial hypertension. So what don't we know about intracranial pressure physiology? Well, actually quite a lot. In humans, we can't just probe healthy individuals. So we don't actually know what normal intracranial pressure physiology looks like. So going on from that, we don't really understand what different disease states, what their effects are on intracranial pressure. So, hypertension, obesity, muscle wastage, different sorts of cancers, any of these things, we just don't know what the effects of these are on intracranial pressure. Moreover, we don't know the effects of xenobiotics on intracranial pressure. So whether that is drugs, environmental pollutants, anything like that, we just don't know. So actually, we know very, very little about intracranial pressure physiology, really, compared to a lot of other biomedical fields. And for us to understand intracranial pressure physiology, we're using idiopathic intracranial hypertension as a disease model. So let me introduce idiopathic intracranial hypertension, or IH, to you. IH is a relatively rare disease that predominantly affects obese women of reproductive age. And it is clear that the incidence is increasing in line with the global obesity pandemic. Diagnostically, IH is a diagnosis of exclusion, whereby individuals must have a lumbar puncture opening pressure greater than 25 centimeters of CSF. They must have papilledema. So if you can cast your eyes to the right of your screen, the top image is of a retina with papilledema. You can see that swelling in the middle. Whereas if you look at the image below, that's the same eye with the papilledema resolved. If papilledema goes untreated, it can lead to visual loss and eventually blindness. So this is a symptom that needs addressing in these patients. Aside from these two positive symptoms, it's excluding other causes of raised intracranial pressure. So the CSF in these patients must have a normal composition. They must have essentially normal neuroimaging, although there's a few features which may well be coming to diagnostic criteria shortly. And they must have a normal neurological examination, with the exception of a sixth nerve palsy. Visual impairment and headache are the predominant comorbidities in IH. And the typical IH headache is a daily debilitating headache, which is migrainous in phenotype. And we know that intracranial pressure in IH correlates with headache morbidity. So a bit on the epidemiology of this disease. It is a rare disease, only 4.6 per 100,000 in the general population, but it is increasing in line with obesity. But what is strikingly clear is that there's a much larger burden in the female population, where over 90% of IH patients are female. The projected health costs in the UK by 2030 is £430 million a year, which is an awful lot for what is a relatively rare disease. But given there are a few different phenotypes of this disease, this presentation and my work focuses on the disease associated with obese women of childbearing age. So in this population, IH is a whole body disease. And over the last few years, this has become abundantly clear. So IH is a metabolic disease. They present with androgen excess, glucocorticoid excess, insulin resistance, adipose tissue dysfunction, and all of this is in excess to that seen in obesity. Moreover, it's a cognitive and psychiatric disease, and it's also associated with obstetric issues. All of this, of course, in itself is an issue, but you have a population of women who are young, should be economically active and maybe wanting to have children. This is an issue. And I think this illustration on the right-hand side sums up the disease pretty well. So as the name suggests, the etiology of IH is unknown. It's a disease of obesity. So is it something to do with the adipose tissue? Is it associated with hormones to do with obesity? Or is it something else? Is it female gender? So is it female-specific steroid hormones? Is it a female-specific endocrinopathy? We don't know. But this is discussing the underlying disease. But what you see clinically is the symptoms of this. So the raised ICP and the consequences of this. And given that IH is a disease of exclusion, we can exclude increased cerebral blood volume or increased brain volume from what's causing raised intracranial pressure. Therefore, it can only be either increased CSF secretion or decreased CSF drainage, which is causing this. However, we just don't know currently what's causing this raise intracranial pressure. But despite all of the things causing this disease, there are treatments available. Should vision be at risk in these patients? Cerebrospinal fluid can be shunted either through ventricular drains, optic nerve sheath fenestration, or temporizing lumbar punctures. We know that weight loss, either in the context of metabolic surgery or diet, is very efficacious in treating the disease, suggesting that adipose tissue is indeed important for the disease. However, diets are difficult to keep the weight off, and not every patient is suitable for metabolic surgery. Therefore, there are lots of pharmacotherapies on the market, which are most often used off-label to treat the disease. And these work by reducing CSF volume. So these are acetazolamide, topiramate, GLP-1 receptor agonists, which pretty soon phase 3 clinical trials have opened for this. So I'm looking forward to seeing the results from there. Corticosteroids have been used, somatostatin analogs have been used, and diuretics. However, the clinical basis and evidence for these drugs is lacking, and they are hampered by quite strong side effects. So better therapeutics are needed. So there are open questions in IH, which we as a group are hoping to address. One, what is the pathogenic moiety in IH? This is something we just don't know. What is the role of obesity in IH? We know that weight loss can be curative in these patients. We know that rapid weight gain can cause disease onset, but we don't actually know what the role of obesity is in IH pathophysiology. We even don't know if the current pharmacotherapeutics is efficacious in IH. A recent Cochrane review suggested that there is no good evidence to actually use any drugs for treatment of IH. And up until recently, we have lacked an animal model to assess any of these. So our research and the data which I'm going to present to you today is 1, to define normal intracranial pressure biology in rats, 2, to assess the effects of obesity on intracranial pressure biology, and 3, to evaluate the effects of acetazolamide and topiramate on intracranial pressure. So on to the first study that I'd like to present to you. Long-term monitoring of intracranial pressure in freely moving rats, impact of different physiological states. And I understand that a link to this paper is in the handouts tab, so just make it easier for you to find the paper. So the aim of this study simply was to measure longitudinal ICP in freely moving conscious rats and assess the effects of different physiological states on ICP. So how did we measure ICP in these rats? Here we used the Caha Sciences intracranial pressure probe, which we have used to measure intracranial pressure. So let me just discuss with you how we achieve this. So if you can see on the figure, we have a pressure tip and a box, and these are connected to by a wire. This box transmits the ICP information to a smart pad, which the rodents reside on. We implant this small box into the abdomen of the rodents. So it's fully internal. The rats can't fiddle with it, because rats quite often like to open things up if they find something that's not quite right. We then tunnel the pressure catheter under the skin, and we drill a small hole in the parietal bone where we insert this pressure tip epidurally. I don't know, in humans, pressure tip replacement makes quite a big difference. Previous work from my group suggests that epidural and interventricular measurements are practically identical in rats. And what you can see on the right-hand side is just a few examples of the pressure measurements and, sort of validating that it works. So a jugular vein compression, which is essentially a Valsalva, increases intracranial pressure, and manipulating the rat's orientation in space can modulate the intracranial pressure as well, in line with what gravity does. So why are we using intracranial pressure telemetry? So we believe this gives a much more physiological way of measuring intracranial pressure. So in these parameters, so social status, if you have a rodent that's tethered, for example, it can only be single housed because rodents will, pick at wires and stuff. The telemetry enables co-housing, thus the rodents can behave normally and without stress, because we know rodents like to be social. Also, because this is fully implantable and can measure all the time, anesthesia is not required. And as data will show later on, anesthesia can have effects on intracranial pressure. Moreover, we don't need to handle the rats as often with telemetry, with the exception of giving them drugs and all that. We don't, or changing cages, we don't need to touch them. Whereas if they're tethered, you have to handle them, maybe sedate them so you can stick a probe on the head and stuff like that. Also, the length of recording here is much more beneficial. If a rodent's tethered, you can only measure pressure for so long, in the order of hours, whereas with telemetry, you can measure pressure 24/7 for as long as the telemeters will allow, which allows for, assessments of diurnal variation, intracranial pressure, amongst other things. And also it reduces artifacts. So if you, for example, using a water-based method to measure intracranial pressure, you'll have a siphon effects on intracranial pressure, movement artifacts on how it's affecting the fluid. Whereas with telemetry, you have minimal artifacts, and anything that is an artifact in inverted commas is something that's occurring as part of normal physiology rather than an artifact of the technology. So on to some results of this study. So we split this study up into three parts, which will be explained as we go along: a recovery period, a physiological period, and an experimental period. But I suppose the headline here is, what is normal rat intracranial pressure? Here in this study and our subsequent studies, we think it's around 5 millimeters of mercury, with about a standard deviation of 1 either side. What I think is actually very important, thinking about historical studies when looking at intracranial pressure, is that we demonstrate that intracranial pressure is reduced following surgery. So panel D and E here. So intracranial pressure slowly increases after surgery, and it stabilizes at about 10 days after surgery. So if you're historically, a lot of stuff is done acutely, so actually the pressure that's being measured is reduced from what it realistically is, which of course that has implications for validity and reproducibility of the work. What was really interesting for us is that how long we can actually measure intracranial pressure for. In this particular study, we measured intracranial pressure continuously for at least 50 days, but we have subsequently measured intracranial pressure for 100 days, and it's completely stable. The only reason you're seeing a reduction in this experimental period is because of animals being removed from the study. But if you actually look at the mean ICP for each individual rat, it's exactly the same. So this is looking at intracranial pressure as a value, but there's more to intracranial pressure than just the absolute value. So here, I'm going to talk to you about ICP waveform features. So if you look at panel A, you can see a typical rat ICP waveform. There's a clear respiratory component here, which happens about once per second. And there is also a noise on this. This is the cardiac component. However, this is unclear, which is quite different to a human intracranial pressure waveform. But I'll discuss this a little bit later. But what this also says, if you look at E and F, is that the pulsatility of the ICP waveform is different depending on if the animal has recovered from surgery or not. If they've not recovered from the surgery, the pulsatility of the waveform is the same. So how much actually increases on the respiration. However, when they are recovered, you see a light dark variation here, where in a rodent, when it's light, they're less active. When it's dark, they're more active. Moving on. So we have what we like to call macro features of ICP. So these features where you look when you zoom out from the ICP waveform. So what we see akin to humans is that we see B waves, which traditionally are seen in pathology, but that's only because in humans you only really measure intracranial pressure in pathological situations. However, we see B waves in rodents in a normal situation, and we also, recent evidence has come out to say that in humans we have B waves as well in normal physiology. So a bit more on the social state and how this affects intracranial pressure. So what we can actually say, if you look at E, is that yes, social state does affect the intracranial pressure of a rat. So we find when a rat is co-housed with other rats, the intracranial pressure is about 2 millimeters of mercury higher than it is when they're single housed. And this co-housing also has an effect on what we see with regards to active versus non-active ICP variation. So looking at D, you'll see that when a rodent is single housed, there is no variation between what ICP looks like when it's light versus dark. Whereas when they're co-housed, you do have an increased intracranial pressure when they're active. Whether or not this is an actual phenomenon of intracranial pressure being regulated by light dark, or if there's something to do with them being social, so they're interacting a bit more, we don't know at the moment. But again, this sort of shows that having animals which can be co-housed, interacting with other rats, is quite important to pick up normal intracranial pressure physiology. So onto the effects of anesthesia on intracranial pressure. So in this study, using hypnomidazolam as anesthesia, we demonstrate that this particular anesthetic reduces intracranial pressure. But what's more interesting here is, for me at least, is how it affects the waveform of the intracranial pressure waveform. So if you look at B and C, B is the baseline waveform, i.e. when the rodents are behaving normally, whereas C is 45 minutes after anesthesia. The main difference between these two is that with B, you have this noise associated with the cardiac waveform, whereas with C, there's a clear cardiac waveform on here, which suggests that anesthesia fundamentally affects cerebral compliance in rats. And of course, this is quite important because historically, when measuring intracranial pressure in rodents, people are looking for this cardiac waveform on intracranial pressure trace. But this work suggests that that could be unphysiological, which you can also see in E with this temporal spectrogram, where you have these waveforms associated with the cardiac waveform between 8 and 5 hertz, increasing in spectral power over the course of the anesthesia. And what's really important to understand actually, does implanting in these rodents actually cause issues with the brain, i.e. does it damage the brain? So in these animals that were implanted in 50 days, we show that this implantation does not cause ventricular megaly, which is one of the main indicators of brain damage. Moreover, using glial fibrillary acidic protein staining to look for astrocytes area, we show that there's no astrogliosis. Therefore, this implantation does not cause any degree of inflammation or astrogliosis, which is really good. So these animals can be implanted long-term. We get really good physiological measurements, and it does not damage the brain, which, that is, that's the ideal situation. So to summarize this paper, long-term ICP monitoring in rats is feasible and is not associated with cerebral pathology. And that measuring ICP in the normal physiological states, including co-housing and the lack of anesthesia, are required to achieve valid ICP measurements, at least when you want to look at true physiology. So now we've discussed on what we believe to be normal rat ICP, I just wanted to dwell a minute on the differences between human and rat ICP. So the biggest difference is that as humans, our spine is pretty much vertical all the time, whereas a rat spine is supine most of the time. So in this, we get some differences depending on how humans are orientated and what the pressure is. So in humans, the normal daytime ICP is around 0 millimeters of mercury, whereas in a rat, it's around 5 millimeters of mercury. But at night time in humans, it's increased to around 6 millimeters of mercury, which again, that sort of makes sense. You don't have the force of gravity pulling down on the water column and therefore causing at the top where the head is reduced pressure during the night, because the water column is not a column anymore. And when we're sort of discussing the ICP waveform between humans and rats, we've already discussed what we see in rats, so a strong respiratory waveform and a bit of noise caused by the cardiac waveform. In humans, it's quite different. Yes, we have quite a strong respiratory waveform, but also have superimposed upon that the cardiac waveform. So this is just important to consider when comparing humans and rodents in the context of intracranial pressure. So now we have a system that works to measure intracranial pressure. We wanted to look at the effects of obesity on intracranial pressure, thus help us model idiopathic intracranial hypertension a little bit better. So here we just wanted to define the effects of obesity on headache, behavior, intracranial pressure, and retinal outcome. So the methods here, we took female Sprague-Dawley rats. We fed them either a 60% by calorie high fat diet or a match control diet. We kept them in an inverted light dark cycle. So when it's dark for them, it's daytime for us. And we subjected them to a battery of tests. So we carried out headache testing during the duration of the weight gain period. We then performed DEXA scans to determine body composition. we scanned the eyes, used optical coherence tomography. Subsequent to this, we then measured the intracranial pressure, where we measured it for 30 days after implantation. So on to the results of this weight gain. Yes, they gained weight. Wasn't a huge amount of weight. We only had a 15% difference in absolute weight. But given we had the DEXA scan, we could delve a bit more. And we can say actually the obese rats had double the abdominal fat mass, which is a great deal more fat. And given that adipose tissue has quite a few cardiometabolic consequences, it was important to confirm this, and much more reliable to this by DEXA scan than dissecting out and weighing fat. So onto what it does to intracranial pressure. Diet-induced obesity does increase intracranial pressure, not to a degree of it being pathological, but to still raise. And one thing that I think is quite nice here is that ICP in these rats correlates to the degree of abdominal obesity, which is what we also see in humans. We also looked at the ICP waveforms in these obese rodents. And what we see is an increase in the subsequent to the surgery. What we see is an increase in ICP waveforms at the 0 to 0.25 hertz. In humans, this is associated with pathological features, and we see this in the context of diet-induced obesity. And what's important to note here is that we only see this after the surgery. So on the day of surgery, where the rats are under the influence of anesthesia, we do not see this. So recovery from anesthesia is required to reveal this kind of information. We also looked at headache behavior in these rats. So to assess headache in rodents, what we do is apply force to the periorbital area, and the force at which they withdraw from that stimulus is considered to be at pain thresholds. And I hasten to add that we were blinded for this. And what we demonstrate is that, yes, these obese animals have reduced periorbital thresholds, i.e. a cephalic pain, which is we see this, for example, in migraine patients. What is also nice is that we see that the periorbital threshold in these rodents is inversely correlated with the abdominal obesity, i.e. the more obese the rat, the lower its pain threshold. We also carried out qPCR on the trigeminal ganglia of these rats, where the trigeminal ganglia is the peripheral ganglia receives neuronal input from the face. Here we show upregulation of the genes encoding for CGRP and TRPV1, where CGRP alpha is one of the main nociceptive transmitters in the trigeminal-vascular system. So onto the retinal morphology in these rats. Here we show on the day of surgery that these diet-induced obesity rats have got a thicker retinal nerve fiber layer, i.e. there is a degree of swelling there. So there's controversy in the field whether or not rats can actually get papilledema, but failing that, they have this retinal swelling, which we see, which is, quite nice. Moreover, this retinal nerve fiber layer thickness correlates with both intracranial pressure and the abdominal obesity in the rats. At the end of the study, we took the eyes and performed histology. Here we show a thinning of the retinal nerve fiber bundle. So what we see is that when we implant the animals, the actual nerve fiber layer is thicker, but the bundle at the end, which is where all the axons are, it's thinner. Interestingly, if you look at eye, you'll see that there's an inverse correlation between the RNFNL thickness and the retinal nerve fiber bundle thickness. So the degree of swelling at the beginning is predictive of nerve fiber bundle thinning, i.e. a degree of degeneration, which is also what we see in the clinic. So the conclusions from this study: diet-induced obesity increases intracranial pressure, causes cephalic sensitivity, alters retinal anatomy, and for us as a group, diet-induced obesity will form a good basis for the development of an animal model mimicking IH. Because, of course, this study is not an IH rats. It is simply diet-induced obesity. Think how many groups looking at obesity in the world. So actually, how many rodents are actually walking about with raised intracranial pressure, decreased pain thresholds, and altered retinal anatomy. So this is quite possibly quite a big confounder in a lot of experiments. Should it be replicated by others? So on to our final study here, the effects of acetazolamide and topiramate on intracranial pressure. As just mentioned earlier, there is no good clinical or preclinical evidence for these drugs. Therefore, we chose to actually assess these drugs actually modulate intracranial pressure at a pharmacological level, because we know that these drugs actually induce weight loss as a side effect. And in the context of IH, where we know weight loss can be disease modifying, and that these drugs have quite a broad side effect profile, it's important to actually, do these drugs have the effects that we believe they have? And if not, there are much nicer ways to induce weight loss. So the methods here, again, this is epidural implantation of an ICP probe, female Sprague-Dawley rats in an inverted light duct cycle. We conducted a randomized crossover study where we administered these drugs orally at clinically equivalent doses. There were two sub-studies here: an acute study looking at the intracranial pressure over 24 hours. Here we administered max human equivalent doses, so 4 grams equivalent of acetazolamide and 200 milligrams equivalent of topiramate. And in a chronic 10-day experiment, we gave the rats equivalent of 2 grams of acetazolamide and 100 milligrams of topiramate. So on to the results here. So this is the acute study, so those higher equivalent doses. We show that, yes, both of these drugs do reduce intracranial pressure to the tune of about 20%. However, combining these drugs together gives a much greater reduction of intracranial pressure to the tune of 40%. And the ICP reduction here is relatively quickly. It takes from administration, which is again oral administration, to maximum ICP reduction is around 90 minutes. So quite a quick reduction. But this does confirm that these drugs do indeed reduce intracranial pressure. But of course, given these drugs acutely is not how most patients will get them. Ignore that for a moment. Let me just talk about this slide. So we looked at the waveforms, the ICP waveforms, and how these drugs modify them. So what we can see here is that broadly in the blue, acetazolamide does just modify intracranial pressure waveforms. We cannot allocate functionality to some of these waveforms between 1/4 to 1 hertz. We just don't have the information to say what they mean. But in the 1 to 2 hertz range, this is the respiratory range of the rats. And what we see here is that acetazolamide and the acetazolamide topiramate mixture increases the waveform amplitude here, i.e. it's increasing respiratory effort, which is interesting because we know acetazolamide causes acidosis, which the body will compensate for this by increasing respiratory effort. So we can pick out a physiological response to a drug by looking at the ICP waveforms, which is really quite nice. But interestingly, despite the fact that topiramate does have carbonic anhydrase inhibitory activity, which is how acetazolamide causes its effects, we do not see changes in respiratory waveforms of topiramate by itself. So chronic administration of these drugs, which is akin to how patients will receive the drugs. So again, here we use more standard human doses of these drugs. So 2 grams equivalent of acetazolamide, 100 milligrams equivalent of topiramate. We again show that the drugs do reduce intracranial pressure, although to a lower extent to the higher doses, which is expected. But what I think is particularly clinically interesting here is panel D. Here we looked at what the ICP does on the average day when the rats receive these drugs. What we show is that the effect of acetazolamide wears off quite quickly at the dosing intervals given, where what would be equivalent to late evening for humans, the effect of these drugs, obviously acetazolamide, is worn off. Whereas with topiramate, the ICP reduction is sustained throughout the entirety of the dosing regimen, which for IH patients is quite interesting because we know that in the mornings they tend to wake up with relatively bad headache, probably due to ICP increasing overnight. And topiramate, as well as having what this appears to be a more sustained effect on ICP reduction, also is used as a migraine prophylactic. But of course, the issue here is that topiramate also comes with an interesting battery of side effects. But it's interesting that topiramate in and itself has a more sustained ICP reduction than acetazolamide. So the conclusions of this study are, one, that yes, both acetazolamide and topiramate do lower intracranial pressure pharmacologically, where in combination they achieve a greater ICP reduction. Moreover, topiramate maintains its treatment effects in clinically equivalent dosing intervals. And although time meant we couldn't go into all the data, our data does suggest that topiramate may function differently to reduce ICP than acetazolamide. Therefore, actually understanding how topiramate elicits its ICP lowering effects may lead to novel therapeutics. So, in summary, we have discussed what we believe to be ICP and normal physiology in rats. We show that assessing ICP in freely moving, non-anesthetized animals is feasible, and that anesthesia, social state, and time of day all alter intracranial pressure. We demonstrate that obesity increases intracranial pressure and is accompanied by clinical features of raised intracranial pressure, such as headache and retinal degeneration. And looking at ICP and pharmacotherapeutics, we demonstrate that both acetazolamide and topiramate lower intracranial pressure. So thank you for your attention, and I invite your questions. Thank you.
Thank you so much for that, Connar. A fantastic presentation. The very first question that we have here is from Frank. This question is, how have you avoided CNS infections?
So we have avoided it by using clean surgical technique. We have never had any issues with CNS infections, but it's probably also partly to how we make sure the pressure probe doesn't move in the rats. So, of course, we drill a borehole to allow the pressure tip to go inside the rats. We put some gel foam on top of that, then we put a mesh on top of that, and then some dental cement. But otherwise, it's just clean surgical technique, and we've never had a rat go because of CNS infection, and we've never seen any evidence of that.
Okay, fantastic. And are you giving them post-op antibiotics?
We do, yes. I can't remember the exact antibiotic we use, but we do give antibiotics. But I think it is more good surgical technique rather than the antibiotics that's doing this. Because we know if something gets into the CNS, it's going to grow regardless of what drugs you give an animal.
Yeah. Fantastic. Okay, thank you. All right. The next question here is, what is the effect of the head down tilt on the intracranial pressure of rats and humans?
So head down tilt in the rats increases intracranial pressure, because you then have the first you have a flexion at the neck, which will of course put some manually increase the pressure, but also you'll then have the effect of gravity pulling down on the CSF column. And in humans, although I've not seen any sort of data on this, I'd assume a simple flexion of the neck would increase intracranial pressure just because of the mechanical forces involved, but I don't have any data currently to back that up.
Okay, thank you. All right, the next question that we have here is, what is the effect of acetazolamide on intracranial pressure at lower doses? So they've suggested a specific dose here, 125 milligrams BD or 250 milligrams BD in humans.
So in our longer study, of course, we gave the lowest equivalent we gave was equivalent of 1 gram, because of course in that chronic study we gave them the drugs twice a day, and we could see even at that equivalent of 1 gram the ICP is reduced, but I can't comment further than that. You know, how low can we go to get pressure down? But I'd say acetazolamide is a lot more variable in its response compared to pyramate, at least in this study. But we didn't try any lower than that. So we wanted to go for what the IH patients would get. Therefore, that's why we chose the particular doses.
Okay, great. All right, we have another question here. This is methods-based question. Are you able to remove the dental cement and reuse the implants or sensors on multiple rats? And if so, can you explain how?
Yes, so we regularly reuse the implants. So it's more of a dental putty, I would guess. It's soft rather than solid. So because of the way we affix everything into the rats, we can just pop off the dental cement / putty, just pull off all the other bits and pieces, and you can literally just pull the telemeter tip out, and all we have to do is remove some of the glue that we use, and then clean it. Of course, making sure you keep the catheter intact and keep the telemeter body attached as well. And we get multiple uses from these. So, of course, depends on how well you handle them and how often and how long you implant them for. But we've had telemeters which we've used 5 to 6 times, and they're still running really well. But they are readily reusable, and which is why I think they're really good. You can use them for multiple studies rather than some other things out there which aren't so reusable.
Yeah, great. That's fantastic. Thanks for that. All right, another question here. This one's long, so I'm gonna maybe paraphrase it a little bit. Are you aware of the clinical meaningfulness / translation of the RNFL changes in the DIO rats?
Okay, so we know that in obese individuals, you do get a slight increased thickening of the retinal nerve fiber layer. Particularly in the context of IH patients, you get this papilledema, which is in effect a swelling of the retinal nerve fiber layer. And so far as what that would mean clinically, if you have a swelling in a nerve, the nerve's of course not behaving properly, so it puts at a risk of degeneration and functional malfunction, which of course when it comes to the retina, that's an issue for humans because we are a visual animal. So anything which can damage the retina can effectively damage our main sense and way of interacting with the world. But what we see there is equivalent to what we see in patients. And we are conducting further studies to actually gain a functional readout of this as well.
Okay, great. And then I guess the second part of that, which you may have already answered, is it representative of intracranial pressure changes, or is it just obesity related changes that are causing that?
So we know that papilledema is a symptom / sign of any increase in intracranial pressure. So an individual might end up getting a diagnosis of a brain tumor because they've been to see their optician. They said, "Oh, you've got this papilledema, you need to go to the emergency department." They get seen, they have a brain scan. It's like, "Oh dear, you have a brain tumor." So it's quite a common finding of raised intracranial pressure. So it's not just an obesity related finding. We believe it's certainly in higher pressures, it is a pressure related finding rather than a specific obesity finding.
Okay, great. And then we've got another question here, which is sort of related. Are the RNFL changes correlated with pressure in the animals that you worked with?
Yes, so we presented that data. There is a strong positive correlation between RNFL thickness and intracranial pressure, which is, we found that interesting actually, because clinically we don't actually see that really, but we found it in the rodents, which surprised us, but it was, nice to see, especially with what are more objective measures rather than some other things that can be measured.
Mm-hmm. Fantastic. Okay, another question here. Why do you think the ICP is different in animals that are co-housed versus singly housed? And is this related to the co-housed rats being more active?
So activity will play a role, undoubtedly, but I think there's more things going on there. So rats are like us. They like to interact with other animals. If they don't, they get sad, they get a bit depressed. So my hypothesis here would be that there would be some interaction with stress hormones, which may actually lower intracranial pressure. This is something that we are investigating, but I think, biological stress will play a role as well, which it makes sense if it does transpire to be the case, because stress affects many other aspects of physiology. So why would it not affect intracranial pressure as well? But that's a working hypothesis that we're working on at the moment.
Yeah, definitely, especially in the last couple of years, being isolated.
Yes, thankfully our rats managed to avoid getting corona. So unfortunately, we don't have a manuscript telling us what corona does to intracranial pressure, which would have been nice, would have published quite well.
That's funny. Yes, it would have. Okay. And just one question related to that. Are you measuring activity in these rats?
We are not directly measuring activity, but we can look at the intracranial pressure trace and sort of work out if they're doing certain behaviors, because of course certain behaviors are quite stereotyped. So we can look at the trace and with a degree of certainty go, okay, are they grooming? We can sort of see when they're resting versus not resting. But we are not directly measuring behavior. But again, that's something we would like to do in the future, which would be very interesting. But we know when it's light in the room, they're less active. When it's dark in the room, they're more active. So we can make generalizations about, in this period, they're less active, this period, more active.
Yeah, definitely. Definitely. Okay, we've got time for one more question here.
Okay.
This question is, were additional subcortical areas analyzed for changes in GFAP?
So we looked at the corpus callosum and we looked ipsilaterally and contralaterally at the superficial area, which would have been in contact with the telemeter probe, and we saw no differences in GFAP staining. And of course, there is no indication of hydrocephalus either. And so far as we can tell, just observing the rats, they also, once they've recovered from the surgery, they behave like you've done nothing to them, but they're quite resilient animals. But in short, we only analysed 2 areas, but in those particular areas, we saw no indication of cerebral pathology.
Fantastic. Well, I think that's going to be our last question because we are almost at the top of the hour. But Connar, I wanted to thank you so much for being here, for your presentation, and also your expertise during the Q&A. It was really a pleasure to have you with us. And I hope you had fun.
Thank you. I did. And thank you for the invitation again.
Our pleasure. In closing, we hope that you enjoyed this Inside Scientific webinar sponsored by 80 Instruments and that you enjoy the rest of your day. Thank you.